Okay, so my name is Jim Gallagher. I'm a burn surgeon and I'm the burn director at Weill Cornell Medicine and New York Presbyterian Hospital in New York City. For 14 years, I've been working on healthcare system development and lower resource settings. And I just wanted to share the framework that helps me to understand how we can all make progress in global health equity and realizing that global health equity progress really requires healthcare systems with surgery. We open by asking the question, what would your life be without surgery? And this, for many surgeons, obviously, you immediately go to the professional aspect, but actually asking the question more on a personal level, using myself as an example, my mother, when she was 25, had to have two lobes of her right lung removed for tuberculosis. Without that sort of life-saving and restorative surgery, she would have never gone on to be the mother that birthed me. And then on my father's side, at the age of 10, he had perforated appendicitis, was in hospital for 2 weeks. And again, without that uh, access to the skill and expertise of those surgeons, my father would never have gone on to be a father. So I think that the impact of not having surgery in a community, using my life as an example, we can see that immediately we have fewer people and people live less well. So I'm going to start. Can't seem to slide advance. Hang on a second. There. I'm going to begin with another kind of story about my deeper past as a surgeon. In 2001, I spent 15 months in the extreme northern province of Cameroon, which is starred there on the map. And the picture that you see before you is of Wanzo, a 26-year-old Cameroonian soldier who shot himself in the face in a suicide attempt after accidentally shooting and killing his commanding officer. He arrived at our hospital 5 days after injury, having received only Valium. And this picture is actually post-injury day number 21. I took no pictures prior because I thought it undignified to photograph somebody that I did not think was going to survive. And in truth, if you saw the earlier versions of his appearance prior to the photography, it was much more distorted. This is actually improved. What you can see coming out of the wound is indeed his brain, the frontal lobe of his brain. He shot himself, pointing the gun up through his mouth and completely destroyed that area. So, as a trained general surgeon in this environment, I thought it would be the right thing to create a tracheostomy. However, the team that I was working with of nurses said that they had never had a tracheostomy and advised me not to do that. I did, however, we all agreed, create a gastrostomy for feeding as he was unable to eat orally. And unclear how to make progress on his wound, I just committed to bringing him to the operating room 2 to 3 times per week to clean his wound, close defects as I was able, and to restore the anatomy as best I could. So these are some photographs kind of midway, cleaning and trying to make progress as I stated. And then after 8 weeks of time with us, this is essentially the best that I could do. I'm pleased that he has reestablished the wound, is gone, overlying his brain. And he actually does have a separation between his oral pharynx and his nasal cavity. However, he's left with a significant defect right there next to his eye that I did not know how to fix. And so he was discharged back to the military with this. So what did I learn from my time as a solo surgeon in the African bush? One, task sharing. When I arrived, they were doing surgery. They were not surgeons. They had the title RN, but they were very much providing surgical care to the community that they served. I questioned my contribution because largely they were teaching me how to work in their context, how to do the procedures that were needed by the community routinely. My advanced procedural knowledge that I had from all my additional training beyond what they had really left with me, and it never became an established part of the care that they provided. And so I really learned also about what is termed surgical backlog, surgery that remains undone in a community. Now, Wanzo benefited from our skill and our care, but at the same time, he left with a problem to walk out into the community that was not lethal, but I could not fix and would require some surgeon in the future potentially to help him. And it turns out that every surgical field has surgical backlog in a society without surgery. And what you see there is a young woman who had a third-degree burn of her axilla, and now she's formed a contracture to close it as she had no acute skin grafting. Surgical backlog, congenital or acquired, has been the target of short-term clinical mission trips for since they began, really. When I came back to the States, I decided that I wanted to make some changes based on what I had learned. And a friend of mine, pictured there at the time, Eric Barquist, an academic surgeon in trauma critical care, said that really to make any kind of change, I would need to join academic surgery. Backlog in general surgery exists as well, not just in plastics reconstruction. For example, a strangulated hernia is a life-threatening emergency that requires immediate surgery. This is how we are taught. But what happens when the patient doesn't die? And it turns out that you end up with a double-barreled ostomy. Most will die from sepsis, but some perforate through the skin, and then eventually the bowel seals around the defect and they go on to live. Surgical backlog, as I said, has historically been the target of surgical mission trips, single disease focused clinics and hospitals. Ophthalmology is a really easy one to point to. It's almost like a surgical version of an inoculation. People are well, walking nearly blind or blind with cataracts, undergo a procedure on one side, so it's not too debilitating, and they can see, and then only to have the other side done at a future mission. Plastic surgery, it turns out, is number one when it comes to backlog in communities without surgery, both congenital here with cleft lip and palate, and then fully half of the surgical backlog in plastic and reconstruction is acquired related to burn injury. The general model of a healthy patient with a solvable surgical problem and making progress by collaborating locally for space and a patient list, importing the team with all necessary equipment and skilled personnel is what we have seen, and still do see with mission trips to address backlog surgical problems. Indigenous efforts at surgical backlog also exist with, say, within the nation of India or Tanzania and similar countries. They'll have surgeons gather in one location, sometimes with outsiders, sometimes not, just addressing the backlog in their community outside of scheduled mission trips. The 20th century's most successful surgical outreach has been Operation Smile, changing lives one smile at a time, and Smile Train. These two separate organizations have been very successful with direct marketing, and each has a budget of nearly or in excess of $100 million a year through directly appealing to the public with regard to this untreated surgical problem. Backlog remediation by missions are largely good and important for those currently suffering. But little changes to the local healthcare system occur. Little development of training programs for plastic and reconstructive burns and LMIC nations is occurring historically with these efforts. They are pivoting their focus in the 21st century, and they're powerful partners. And I put the box in red with regard to their income every year to see that, the kind of resources that these many different NGOs have really shows that they need to be part of the solution and be partnered with as we move forward. So take a step back now to the current situation and what we know. What comes first? The poverty that we see in low and middle income nations of the world, or the underserving healthcare system that lacks surgical care? And how could you even approach the and what you go after first is the healthcare system that's underserving, and then this will, in time, fix the poverty. This truth came about through a landmark. Here, I'm showing you a landmark from the United States. A landmark is something that changes things, an event or a development that marks a turning point. This out west in the United States really doesn't look like any other hill and can't be mistaken. And therefore, if you're given directions when you see it, it's a reliable way of knowing something has changed. Within global surgery, the landmark I'm referring to is really Global Surgery 2030, which was published in April 26th of 2015, almost a decade ago now. This is a tremendous article. First of all, it's published in The Lancet. The Lancet put together a commission on global surgery. That commission consisted of international contributors from more than 110 countries, providing an outline of the global situation of surgical care and direction for making and measuring progress. 3 key points from a tremendous article written, as you can see, by so many different people that took me a week on vacation to understand to some extent. But I'm going to give you 3 really, I think, key points. 1, 63% of the world's people lack access to safe and affordable surgical care. 2, a nation investing in its healthcare system can expect a 10-fold increase in their GDP with time. To make a positive change, it is the nation that must take the first step. They do this by creating a national surgical, obstetric, and anesthetic plan. I highlight again that it is the nation investing in its healthcare system that's primary, and that this investment will yield a 10-fold increase in GDP. What are the facts of global surgery? In 2010, 16.9 million deaths worldwide from conditions that need surgery. This figure far exceeds the 1.83 million deaths worldwide from HIV, AIDS, tuberculosis, and malaria combined. This situation is worst in low and middle income countries, where as many as 9 out of 10 people do not have access to basic surgical care. Taking a look at the foundational nature of surgery in healthcare, this is a graph of the global burden of disease categories. On the left, we see 3 main categories: communicable diseases, non-communicable, and injuries. And on the bottom, we see the frequency of procedural need, the surgical need. And you can see that even, say, mental health, which has the lowest need, still has a need for surgical procedure. Basically, you cannot attempt to strengthen and produce a robust healthcare system without surgery. So how do we make things better? We need healthcare systems that have surgery. So going back to the National Surgical Obstetric and Anesthetic Plan, the Lancet Commission on Global Surgery contains the actions that the nation must take to strengthen the healthcare system. The NSOAPS plan, as it's commonly referred to, has 6 main domains: governance, infrastructure, workforce, information management, finance, and service delivery. Keeping in mind that these are directives for governments, not for individual people. And for example, the financial piece gets tied to the national budget in a proportionate way, with the idea that it would grow as the GDP grows from using the from enacting the NSOAPS plan. Each of these NSOAPS plan is unique, initiated, and authored by an individual nation. And it, again, means that the nation is committed to improving surgical capacity and quality, and they take this first important step. If we look at a world map of poverty, the percent of the population living on less than $2 a day, we can see that, as we know, I think Africa is disproportionately um, uh, poor. However, it's these same nations that are showing the most robust NSOAP's progress. This is a world map of NSOAP's planned activity to date, with green being those who have completed, purple being those who have begun the process, and blue being those who have committed publicly to creating an NSOAP's plan. Low-income nations recognize that to prosper, the way forward is to invest in their healthcare systems with surgical capacity. The problem with the Lancet Commission in Global Surgery 2030 is not its lack of truth, but rather exact implementation plans for how to move care currently forward at the bedside right now. The plans are really for governments and reassuring that things will be moving positively once enacted, but how to move things forward now. For a moment, though, we're going to look at first the impact that this new truth, this landmark paper, has had on the world surgical community. So professional organizational partnerships exist in a way that they haven't before. The American College of Surgeons has partnered up with the College of East, Central, and Southern Africa. In the bulletin published May 10th, just in this past year of 2023, ACS Training Hubs Help Build Surgical Capacity in Africa is the title, with the goals being expansion of surgical services at training sites, recruitment of external examiners, twinning of scientific journals, educational resource sharing, access to ACS leadership programs, scholarship for women surgeons, with the plan being, as exemplified in Ethiopia, called Hawassa is the actual location. The pilot began in 2019 with 13 U.S. academic centers with global surgery programs committing to participation, each with 2 weeks on the ground, creating a year-round on-the-ground presence of U.S. surgeons at Hawassa. Zambia was to be the next nation. Its process has been moving slow. Remember, COVID has been in the middle of all this, and it only now really truly seems to be under control. And then I highlight Rwanda because Rwanda kind of got tired of sitting in line and has moved forward with activities with the American College of Surgeons and COSEXA to produce surgical capacity in the subdisciplines. In February 2023, they got started. I was actually a visiting professor through the ACS to this program in Rwanda for plastic reconstruction with the sub-focus of burns at the residency program in Kigali, Rwanda. And this is felt to be scalable and reproducible as reported by leadership of these two professional organizations. The impact of the Lancet Commission on Global Surgery was also recognized by the American Surgical Association. This is the oldest professional surgical organization in the world. It was established in 1880. And they got together in October of 2018 and published an article by forming a working group within the American Surgical to figure out how they recommended we act on global surgery and the problems that were identified. So again, published in October of 2018, Annals of Surgery. And one point that I'll put forward that from that article is that there is no consensus on the most effective roles that U.S. academic departments of surgery can play in global surgery. So unclear how to move forward. The answer on how to is not in the Lancet Commission, as I've sort of said, exact implementation plans on how the community of surgery can assist a nation that's completed its NSOAP's plan. However, in this same article, they mention that major actions to improve this situation, meaning the situation with minimal surgery in the LMIC nations, will be aided by actions taken in surgical communities, institutions, and governments of LMIC nations. And so, how to might best be approached by discipline, i.e., the surgical communities. So, holding that thought and now moving in another direction, something put forth essentially by the WHO is the concept of a surgical macrosystem of surgical care, i.e., a stakeholder community. Everybody who's concerned about a given surgical problem. Every surgical discipline has a stakeholder community that surrounds whatever the problem is. So at the center, there in sort of this pinky purple color, we're looking to improve problems that require surgery. The NSOAPS plan remains in support of all of this work, but this is a discipline-specific community now, a stakeholder community. And the NSOAPS plan is really for the nation to support the efforts. So we have academia, professional organizations like the American College of Surgeons and COSEXA, which is different from academia. The local government, who really leads the charge and has to undertake the first steps in order for programs to be successful. NGOs, a huge group. The world government is going to be more of an influencer, sort of accepting and supporting what's being done, but is not going to lead it or provide large amounts of funds. Industry is an important partner as surgery has consumables, things that we use. So industry needs to be included. And then finally, philanthropy. I have found this stakeholder community group construct very helpful when trying to understand different projects, keeping in mind that you may find different organizations that have become hybrids of the 7 distinct groups. And SOAPS is in support of a community of stakeholders. And I think it's important to reemphasize again that it's the local community that owns this and has to be the one driving things forward. So I want to share with you now the impact of what's happened. When you think about the stakeholder community, what we are seeing today as it matures is a unification of stakeholders. The Global Surgery Foundation officially got launched at the World Economic Forum in 2020. The Global Surgery Foundation is the largest group of stakeholders together with one voice. So we have representation from professional organizations, philanthropy, academia, and NGOs all together under the Global Surgery Foundation. What's missing is the world government. So the world government has its own arm in this regard called UNITAR, the United Nations Institute for Training and Research. They remain appropriately separate in some sense and collaborative with the Global Surgery Foundation, but not within it. Local government doesn't really make sense in that each one of these initiatives once it's taking place in an individual country, will have the local government, but local governments wouldn't be involved in the worldwide effort at unification of stakeholders. And industry is always an important one to think about, I think, separately, again, because they are sort of in it to, for them to try and make money, but also in a way that is collaborative with the rest. And so I think appropriately with the Global Surgery Foundation, no individual industry is a part of that organization. So what kind of products are we seeing from the highest level surgical communities in light of the great need that was identified by the Lancet Commission in 2015 Global Surgery article? So UNITAR, the United Nations Institute for Training and Research, has put forth Surge Hub. It's a learning hub. It's completely free online. You can have it on your phone or your computer. The idea is to have both surgical care and non-surgical care related available in real time with videos and lectures that have been vetted by the communities, and anybody can use that platform and use the tools, and the education is there. So all courses in global surgery in one place, free and open for the world. Again, open access, all disciplines, and partnering with Global Surgery Foundation is an important thing to note, as this is really something that is on the highest levels of surgical care from the planet level, really. All members of the surgical macro system getting together to develop a world resource for education is what this represents, and brand new in the fall of 2023. So a summary of the first part of my lecture, I'd say number one, there is hope. Improving healthcare systems with surgery makes fiscal sense, raises the GDP of a nation. Surgical leadership is answering the call. The American College of Surgeons and COSEXA are forming an alliance to improve surgical education, create more capacity. We must recognize on a discipline level the stakeholder group and the macro system to try and understand the role that everyone plays. Then we're seeing collaborative stakeholder organizations to help develop common visions for advocacy and plans. And now we're seeing products like SurgeHub, a new product from UNITAR, from the United Nations, collaborative new kind of learning environment for all disciplines. But this discussion, again, has been really an overview so far of global surgical systems improvement for the entire surgical community. Going back to the question I posed earlier, how do you build sustainable bedside care systems in LMIC nations right now for surgery? And the example I'm going to use is the one that I know best, as I'm a burn surgeon, and I've been working for 14 years on and off in Tanzania as part of my position in New York. So for those who are non-burn surgeons, we're just going to take a moment to talk about burns. From an epidemiologic perspective, burn care could be thought of in this giant triangle as the societal burden of burn injury, with the goal of making things better. We want less suffering, less disability, and less death. As we increase in severity, burns getting larger and larger and larger, there are fewer and fewer of those kinds of patients. However, when burns can be are smaller, and the numbers are enormous in a society. So in order to make a difference in the whole triangle, from a labor perspective, we have to think about the big numbers as well as the small numbers and how we're going to approach both. And to address the big numbers, to have an impact there, we're going to need prevention and first aid that's distributed, education by healthcare workers in the community. And then immediately, once someone is burned, pretty quickly, they're going to meet a nurse. And so we need a tremendous amount of nursing. And that nursing need continues all the way up until the large burns. We never obviate the need for nursing in burn care. And then once you have a significant burn that's at risk of contracture formation, or any burn that's going to be hospitalized for any length of time, we have a rehab need, both for splinting and exercise maintenance and collaboration towards recovery. And then we do need a doctor to make rounds to make sure that medicines are appropriate and pain medication is available, for example, to work with the nursing staff to move care forward. And finally, we will need some surgeons who are able to, or even maybe not surgeons, people who are able to and willing to skin graft effectively to close wounds in burn care. And finally, we do need plastic surgeons. The burn care falls in the field of plastic reconstructive surgery as a subdiscipline. And a lot of burn care can be done without plastic surgeons, but I think it would be wrong not to consider their important contribution, although they're needed in much fewer numbers compared to the rest of the team. So progress top down, versus bottom up. What do those two things look like? Training programs. So if we're going to make progress from the top, we're going to need to train plastic surgeons and others at training sites to do a good job with rounding on burn patients and handling complex contractures, as well as skin grafting. So we need that. But also we're going to work from what we call the bottom, or what does that really look like? And this is building teams, non-surgical burn care, the appropriate first aid and prevention for healthcare workers, all the burn care that's provided by nursing, rehabilitation, and medical staff, team members who are not doing surgery and helping with burn patients move successfully through the process to home. So I'm going to now go even more specific into Tanzania. 95% of burn injuries occur in low-income countries, of which Tanzania was one. Before July 2020, it was a low-income nation. It has now become a low-middle income nation. Tanzania's healthcare system needs to serve 62 million people, about the population of the UK. And the goal is to build a model of burn care that's going to help the entire population need for burn injury treatment. So keeping in mind this severity triangle from epidemiology, along with the different kinds of workers we're going to need, and again, the severity being high at the top where there are a few numbers, et cetera. And then we are going to need to build training programs at the top, plastic reconstructive burn surgery training. The first one opened in Tanzania in 2022. And this is creating leaders, but really is not increasing the capacity from an epidemiologic perspective. So from a population perspective, the epidemiologic perspective, we need to build a model where we can build teams from existing assets and build within existing infrastructure and really sustainably. And what does a sustainable project mean? It means minimize the external operational support for the care. What makes a care delivery project sustainable? This word is used a lot, but what do the experts say? Well, Melinda Gates is in charge of a lot of philanthropy, and she's got tremendous high-level advisors that help her to make good decisions with the resources that she's in charge of. And she says all philanthropy is a spark, that you really have to have it be in a sound system in order to expect growth, that you can't depend on outside resources indefinitely. And then Paul Farmer says, for care development to occur, we need to consider at least staff, stuff, and space, and what the needs are for those three things. And they really can't come from philanthropy. What we need locally is well-trained personnel, appropriate facilities, and supply lines for consumables. All that funding has to come locally. These are operational expenses and cannot be dependent upon outside sources. Capital costs can definitely come from outside, multiple stakeholder involvement from an academic center or some partnership can lead to the purchase of important capital equipment. And this is not foreign to us. The same kinds of things happen, I know, at my burn center. When we have a great need, we look for philanthropy for capital equipment and physical plant changes, et cetera. Sustainability is not only defined by how the resources are used, and I keep reiterating this because of its importance, that the effort must be owned and desired by the local community, or when there are certain champions, when they move on, the project will collapse. So it has to be owned by the local government and the local center. Sustainable model for burn care, for burn teams development in Tanzania. I began a collaboration more than 10 years ago now. The young woman there in the corner, Katrina Mitchell, today a breast surgeon in California, when during her research time helped me to get the very first grant to help begin sort of more formalized burn care in the area of Tanzania that I visit. Space. So addressing now the sustainability issues here in the future. That is a picture of Weil Bugando Hospital. This hospital is part of the Catholic Church in collaboration with the Tanzanian government, is a zonal facility, almost 1,000 beds. And it's within this space that the hospital said, you know, we need a burn center. So not an external building, but rather they gave a hallway and all of those rooms became the burn center in 2015. We have been developing a model, myself and the local team, for a renovation, which hopefully is going to be coming to improve the space. But again, the renovation external funding is more like a capital equipment expense, whereas the space is already a part of the institution. A staff perspective, as soon as the space was created, there's automatically a nursing staff. So they immediately become burn nursing. That is your burn nursing staff. As long as they are present, they're there, become more and more expert at burn care and are a fertile ground on which to have education time and exchange with regard to burn care in their environment. And that's what we do in my visits through the years, working with this team and help them to make sure that we all agree on basic principles of burn care and how they provide care in their setting. This man is today the director of the Plastic Reconstructive Burn Center there at Bugando on J5. We met very early in his training, and he has now all the way come through. He's the first plastic and reconstructive burn surgeon in the region, and one of very few in the whole country. And then professional development is one of the things that I focus on. He's there again in a suit of dark red, along with a nurse and another surgeon from the largest city in the country, all who are involved in burn care, along with my fellow on the far right. We are together at the Pan-African Burn Society meeting in 2018 in South Africa. In 2022, in collaboration with the NGO Interburns, we put on a major training for the nation of Tanzania with a few attendees from outside of Tanzania, focusing on team building and taking care of burn holistically and the development of burn center care over time. So burns need dressings. This is a little guy who has a scald burn and doesn't necessarily immediately need surgery, but he certainly needs dressings, and dressings are very expensive. The workhorse dressing at the burn center in Tanzania at Bugando Hospital is a banana leaf. They own the process. And it's literature-based, the literature mostly coming out of India, but they've contributed to the literature in 2021 with a comparison of banana leaf dressings versus conventional dressings for their children. And again, things like a mesher, which are very disproportionately expensive, are main goals for capital equipment when I go. So what do I bring to this situation? I bring content expertise and trying to help us all to go in a direction that makes sense in burn care. I offer mentorship and education, professional development. I try and source capital equipment and stakeholder introductions, other NGOs like Interburns, who now has an independent working relationship with the burn team at Bugando. Global surgery focus beyond the bedside. The American College of Surgeons, major actions to improve the situation needs to be taken by communities, institutions, local governments, as I stated earlier. High-income nation professional societies directory maps. So within burn care, but no longer discussing the sustainable project at the bedside, looking at how we are all connected. How do we create this community to be together to make progress? Well, in high-income nations, we've always had these directory maps. There's the European one, the Australian one, and the US one. And there was an effort at one time to make an African map. This effort was endorsed and hosted by the International Society of Burn Injury. Cameron Gibson, my fellow at the time, worked hard on it. And what you see was sort of the vision of the world, that we would link together the existing maps, and then the Pan-African Burn Society would eventually own the African map, intermittently or in the interim, hosted by the ISBI. So here is the opening slide regarding this initiative. from the talk that I gave on December 4th of 2018 in Durban, South Africa, about the importance of the map and the efforts that were being made. In parallel to all of this, in March of 2018, I was aware of this effort going on in the pediatric neurosurgery community. These two gentlemen, Dr. Harkness and Dr. Johnston, along with a group and quite a bit of funding, were able to put together really an incredible, comprehensive worldwide map that would allow the community of surgery to grow, again, particularly just in pediatric neurosurgery at first. But if you look across the top, this is now done in cooperation with UNITAR. So this is the WHO says this is the way to form community in a modern world, along with the Global Surgery Foundation, i.e. the highest level multi-stakeholder group, and the G4 Alliance, which is similar but slightly smaller than the Global Surgery Foundation. But again, a very important voice for collaborative work in a surgical community of today. In the fall of 2023, the burn care community became the first surgical community to approach the ISBI. We approached Intersurgeon with their worldwide professional organizational map, and we wanted to be able to enable isolation of our community on the map. So the ISBI paid, in collaboration with Intersurgeon, to have the map modified for burn care, which is live today. So you can sign up on Intersurgeon and then click burns, and you'll only see burn care providers throughout the world. And it's not just providers, NGOs, academic institutions, anyone involved in burn care can be on the map. And it is not just physicians, nursing, rehabilitation, the entire multidisciplinary team. Intersurgeon is not just a map. They also offer a matching function where people can post something that they have and someone else can post a need, and the map function, matching function could potentially put them together. Topics, for example, would be clinical assistance, education, research, training, and surgical equipment. And then other NGOs have jumped on and partnered with Intersurgeon, recognizing the truth that this is an incredible effort at community formation in surgery. Of note is Help Lightning and Ohana, both trying to make it possible that a surgeon in real time, or an operator, it doesn't have to be a surgeon, someone doing surgery, could get help remotely using provided platform with an iPad and Google Glasses, linking them together to perform a slightly more advanced procedure than the operator could otherwise do. Back to the beginning again, 2001, when I moved to Cameroon with my family to provide surgical care in a rural location for 15 months. What did I bring with me? I brought with me the textbook that I was told to buy as a resident, but didn't really find it very useful. Rather, I found these two books, Primary Surgery, very useful, Volume 1, actually published back in 1987, still useful today, with important information for working in an LMIC nation. And within there, I find this graph, which is the surgeon all dressed up and ready to work, but not working actually. Instead, we find a graph with the quality of surgical care increasing in the upward direction, and then time along the x-axis. Surgeon A finds a great system, and somehow just all they do is maintain it, and they retire from a great system. Surgeon B finds a great system, and through their mal-leadership leads to deterioration in the system that they are working in and led. Surgeon C finds a bad system, and over time is able to improve that care and improve the system. And Surgeon D finds chaos, maybe does good surgery within it, but doesn't try to improve the system that they're working in. I don't think it takes long once you see this graph to realize that everyone involved in surgical care wants to be part of C, wants to be improving surgical care, not just for an individual patient, but for a system. And then it doesn't take long once you're mature in your profession to take a longer view, especially with the information provided by Global Surgery 2030, that how do I be a part of improving the surgical system on the whole planet? And so the book that I recommend now is a book that's really written for high-income nation physicians going to low-income nations, authored by Beth Hockman, who is a global surgery person, trauma surgeon up at Columbia. She's was authored with Dr. Hardy, and How to Work and Teach in Low and Middle Income Countries just came out in 2023. I want to just share some other perspective with you from Butaro, Rwanda, a trip I made in February of 2023. So this is a medical school that is really one of the crowning achievements of Paul Farmer and that entire group of Partners in Health. They created a really first world 21st century medical school in the rural bush of Rwanda at the district level hospital. And I attended a lecture there, and a couple of points were emphasized that I recognized, which was that excellence in academic medicine, which they are trying to obviously achieve in this location, includes clinical care, education, and research, much like the three missions you'll find in almost every mission statement in academia. However, what they pointed to is that healthcare system strengthening was a new and distinct expertise in addition to these three. Parts of each one of these are included in it, but really was a distinct specialty in academic surgery in particular. So my summary for the second part of the lecture, we need to build from the top. We need to make surgical training programs like are being done by the American College of Surgeons and COSEXA collaboration. But we also need to consider building teams, looking from the bottom. We need to be focused on prevention, outreach, triage, non-surgical and surgical care. When we think about making solutions for burn centers that are going to serve a population, we have to have sustainable solutions for staff, stuff, and space. We do need community in order to make any kind of progress. Global surgery is no longer just humanitarian service, but rather a new academic field from which people can gain advancement. I want to take a moment just to mention healthcare in war. Oftentimes people say, "Are you with Doctors Without Borders?" when they learn of the work that I do. And I think it's important to understand that Doctors Without Borders and all are medicine in relief. The photo that I'm showing you there and the screenshot of the burn prevention program in the Ukraine, which was really a model for the world, and all that literature still exists, was put together by Glenardi Fusilov. I met him along the way in the years before the Ukrainian-Russian war. And he did this great work, which of course has been wiped away now because of the war in the Ukraine. So we need peace in order to have medical system development. Doctors Without Borders and the International Committee on the Red Cross are important organizations who step in the event of war and build infrastructure to care for people in the midst of war. But what we've been discussing till now is really building in peace. So healthcare system development requires peace. I wanted to thank my community at Weill Cornell. These are my partners. Without them, I wouldn't have any time to step away and do the work that I do internationally. These are my mentors that I've relied upon through the years to get to where I am. These are the burn teams that I'm a part of. The one on the right with the glasses on there in blue is my team in New York. And on the left is a party in Tanzania from past, bringing together burn care providers. These are my international mentors, people that have meant a lot to me through the years and encouraged me in the work that I do. And these are the organizations that I've been a part of that continue to help with burn care development throughout the world. And of course, philanthropy. I could not have done the work over the years without the generosity of many people who've contributed to the project. And my family who allows me to go and parts with me. So we need healthcare systems in the world for people to prosper. That is health equity. The boy on the left suffered a flame injury, about 28% right before I met him. and there would be no grafting for him in many parts of the world. The boy on the right had a similar injury, and this was the day of his discharge. His body has healed as much as it can, and now he needs skin grafting. With no skin grafting coming, he's being discharged from the hospital. Better is possible. I met the boy on the left there, and that's him on the right when we grafted him acutely during the visit that I was on. So we increase GDP. We have ACS training hubs helping to produce um, uh, progress from the top down. These are all the points that I've made during the talk, and I thank you and would be happy to answer any questions.